to introduce my colleague, Erin Buckley. We are both over at the Emory side of the BME department. Erin's background is in physics. Her PhD is in physics from UPenn, and in her postdoc, she was in the neurology department at both the Children's Hospital of Philadelphia as well as Mass General Hospital. So, thanks, Erin. Take it away.
So, if you guys don't mind, I'm going to sit because I went to the Packers-Falcons game last night, which was awesome, but I didn't get home till 2 in the morning, so I took some notes on my slides just so I don't forget what I'm supposed to say, because I got about 3 hours of sleep. So let's see. Can everyone hear me? We're good. Okay, so today I'm going to tell you about how my lab uses light to non-invasively study the brain in both health and disease. So the physical principles that underlie the methodologies that we use, which are kind of collectively known as diffuse optical spectroscopies, are probably well known to most of you here, whether you are familiar with it or not. So if you've ever taken a white light flashlight and shown it on your hand, what you notice is that your hand glows red. Unlike, say, X-ray, you also don't see any distinct features of your hand. You can't make out bones or blood vessels. Your hand glows red, and this is because light is diffused through the medium. So if we look more closely into this, the reason that your hand glows is because tissue is highly scattering in the near-infrared region. And it leads to this diffusive transport of light. So you can think of photons as traveling on a random walk as they go through the tissue and they bounce around. And we can define the average random walk size as this parameter μs prime, or the reduced scattering coefficient, we call it. And the inverse of that scattering coefficient is equal to this average random walk step size. So here I'm plotting this parameter as a function of wavelength in the near infrared. And you can see it's on the order of about 10 inverse centimeters, meaning that photons are going to propagate about a millimeter between every scattering event. And the scattering direction is basically randomized, and so that's what makes them diffuse all in different directions. And the second feature that causes this glowing specifically in the red, is that tissue is also highly absorbing. So now I'm plotting the absorption coefficient of tissue, which is defined as the average, or the inverse of the average photon travels, average distance a photon travels before being absorbed. And what you can see is that it's on the order of same order of magnitude as the scattering coefficient, and this is for the two main things that absorb light in your tissue, which are oxy and deoxyhemoglobin. So it's quite high, and this is the visible spectrum just for reference. But in the near infrared, there's this nice window where absorption is quite low. And so light is able to penetrate quite deeply. And then, moreover, if we zoom in on this near-infrared window, we can see that the absorption coefficient is on the order of 100 times less than the scatter. They're not asking a question, right? Okay.
No. Folks at Emory, can you please mute your microphone?
Okay, so this absorption coefficient is on the order of 100 times less than our scattering coefficient, which just means that the light is able to penetrate deeply before being absorbed. One more thing to notice on this plot is that there are spectral differences between these chromophores. So you can see deoxyhemoglobin absorbs more at the lower wavelengths, oxyhemoglobin absorbs more at the higher wavelengths. And so we can make use of these spectral features in order to isolate the components of individual chromophores. So since I'm applying this principle to the brain, I often get asked, can you measure through the skull? And the answer is yes. So we actually got a skull from an anatomy lab, and we took a laser and shone it through the interior of the skull, and you can see the light diffuse through the skull. So basically, the general principle is we exploit this window of low absorption in the near infrared where light can deeply penetrate. We have two technologies that we use. One is called near-infrared spectroscopy, or NIRS, and the other is called diffuse correlation spectroscopy, or DCS, and I'll go into a little more detail on these methodologies in the further slides. But the goal of these technologies is to apply them to the brain, extract relevant optical properties of the brain, so absorption, scattering, and then this diffusion coefficient, we call it. And then, most importantly, we then relate these optical properties to physically relevant parameters that clinicians can use to guide patient care at the bedside. And specifically, we're monitoring things like oxygen saturation, blood volume, blood flow, and oxygen metabolism. So in particular, I'm interested in pediatric brain monitoring. And the reason for this is because, as opposed to adults, where there are many different modalities that you can use to monitor the brain, like MRI, PET, SPECT, TT. In kids, the monitoring modalities are a little more restricted. So you certainly don't want to expose children to radioactivity if you can help it. You don't want to do anything invasive. Most importantly, kids move around a lot. So if I think the rule of thumb is, like, if they're under 6 years old, they need to be sedated for an MRI scan. So obviously, we want to avoid sedation if at all possible. And then when patients are critically ill, like this baby in the cardiac intensive care unit, transportation can be quite difficult and require a full team of people. So that's not to say that there aren't modalities that can be used to study the brain in kids, right? So there's EEG, which is used to monitor electrical activity, but doesn't tell us about the hemodynamics of the tissue. There's commercially available NIRS systems, which are really used as monitors of trends in cerebral saturation, but are hard to compare from patient to patient, and I'll talk about that a little more later. There's TCD, which is used to measure blood flow velocities in the large feeding arteries to the brain, but doesn't tell you about what's going on at the microvascular level. And then there's technologies like MRI or CT, which give these beautiful images, right? But they're really just a snapshot in time. And then when you've got really critically ill patients, as soon as they leave the scanner, now we no longer know what's going on. So there's really this niche for non-invasive bedside cerebral monitoring in children. I guess I should specify in patients like this who are really critically ill and unstable. So like I mentioned, we use two different techniques, near-infrared spectroscopy and diffuse correlation spectroscopy. And then specifically in our near-infrared spectroscopy system, we use what's called frequency domain NIRS. So what we do is we send in amplitude modulated light. And obviously, like we talked about, the light goes in, it scatters around, and some of it is going to reach our detector that is positioned some distance r away. And that detected light is going to have an amplitude attenuation and a phase shift that is related to the optical absorption and scattering properties of the tissue. So we can make these measurements of phase shift and attenuation at multiple source detector separations and use what's called photon diffusion theory, which basically governs how light propagates through a turbid medium like tissue. And we can relate these parameters as a function of separation to absorption and scattering properties of the tissue. Basically, the slope of these lines is proportional, is a function of mu a and mu s prime. And then furthermore, we do this at multiple wavelengths. And so by doing that and exploiting those spectral features of oxy and deoxyhemoglobin, we can extract concentrations of oxy and deoxyhemoglobin in the tissue. And then from oxy and deoxy, we can get total hemoglobin concentration. We can get oxygen saturation, which is just the ratio of oxy to total. And we can get blood volume, which is essentially just proportional to total hemoglobin concentration. We can also model, using this diffusion theory, how light propagates through the brain. And what we see is that there's basically this banana-shaped probability of light penetration. And farther apart we place our source from our detector, the deeper the light's going to penetrate on average. But obviously we can't put our detector too far, otherwise we don't collect any light. So we're always balancing the signal to noise with depth penetration. But on average, we're probing surface cortical features. And because of this diffuse nature, we are really most sensitive to kind of the bulk optical properties of the region under our sensor. So we report a number. It's a spectroscopic measurement. And the reproducibility of these measurements, at least in babies, is around 10% for hemoglobin concentration, around 5% for oxygen saturation. So it's quite robust measurement. So then a complementary technique to FD NIRS is diffuse correlation spectroscopy, which is used to measure the dynamics of the tissue, and by that I mean the flow in the tissue. So as opposed to NIRS, where we were sending in RF modulated light, now we send in a coherent light source. And so again, the light goes around, it bounces through the tissue, some of it reaches the detector, and if we actually looked at the tissue surface, what we would find is that there's this speckle pattern of interference of electric fields that have all traveled along slightly different path lengths through the tissue and add constructively and destructively. And so what we do is we just look at one of these speckles. So we have a very small detector fiber and we sense one of these speckles and we track its intensity as a function of time. So if all the scatterers, the light scatterers in your tissue were totally static, then the intensity would just be constant, right? But when the scatterers start to move, you'll start to see small fluctuations in intensity. And as they move faster, those intensity fluctuations speed up. And so we use what's called an intensity autocorrelation function to quantify the rate of these intensity fluctuations. It's just basically the intensity at some time t times the intensity at time tau later, normalized to intensity at time t. And I should point out that the main moving scatterers in tissue are red blood cells. So basically the decay rate of this autocorrelation function tells you about the speed of the red blood cells in the tissue. So this is patient data that we took. We had an optical sensor that we strapped to a patient's forehead. We had them breathe room air and then gave them inhaled carbon dioxide, which is a potent vasodilator, right? So blood flow should increase. And the red curve was taken during room air and the blue curve was taken during hypercapnia when we have increased blood flow. And so you can see that an increase in blood flow is denoted by a left shift of this autocorrelation curve. So just like how we had photon diffusion theory that described propagation of light for NIRS, we have what's called correlation diffusion theory to describe simple models for this intensity autocorrelation function. And we can use them to extract, we can fit this data to very simple models and extract a blood flow index in the tissue. I call it a blood flow index because it doesn't have the traditional units of flow. So it's essentially a flux per unit time as opposed to a volume per unit time. But we've done numerous validation studies now to show that this blood flow index correlates very well with blood flow measured with other more gold standard modalities. So then importantly, when we combine our FD NIRS measures of oxygen saturation with our DCS measures of blood flow, we can extract oxygen metabolism. So given that 90% of ATP production is generated through oxidative metabolism, this CMR2 measurement gives really a more robust picture of neuronal health. So we quantify CMR2 using what's known as Fick's law, which just states that oxygen utilization is equal to oxygen delivery times oxygen extraction from the tissue, where like CaO2 is your arterial oxygen content, CBF is blood flow, SaO2 and SvO2 are your venous and arterial oxygen contents. And so we use DCS to get the cerebral blood flow component. We use NIRS to get our saturation component, the venous saturation. And then pulse oximetry or arterial blood gases, if our patients haven't, which oftentimes they do, to get our arterial oxygen content. And so again, we arise at this index of oxygen metabolism, which doesn't have the right units, but we've seen through validation studies, which I think I'm actually going to show one, that it agrees well with other gold standard modalities. So like I mentioned, there are commercially available NIRS components available in the clinic. I think commercialization began in the 80s. NIRS has been around to some degree or another since the early 70s. They started commercializing it, and I have to say, it really just it hasn't taken off. It's certainly used in some ICUs across the country, but there's a lot of challenges. So first off, these systems are very technologically simple, and so they have to make a lot of assumptions about path link factors and scattering of the tissue, and what ends up happening is it makes it very difficult to compare patient to patient or day to day. If you take the sensor off and put it back on, it's hard to compare. So it's most useful as a trend monitor of regional oxygen saturation. And then moreover, if you want to use it as a monitor of oxygen metabolism, which is really what the aim is when you're trying to monitor these hemodynamic parameters in the brain, it's really an insufficient marker of metabolism, and when you look back at that formula, you can see why, right? So it's basically just this component of the formula, and without the delivery piece, it's very difficult to say, make an assessment of the patient's brain health. And my colleague, when I was up in Boston, did a nice study where she looked at neonatal brain injury in the acute phase. So she had 14 brain injury patients. Most of these were hypoxic-ischemic injuries, and 19 healthy controls. And she measured with NIRS during the first week of, during the first 2 weeks of life, and then measured with MRI to get metabolism. And so with NIRS, you can see that there's really, so yes, oxygen saturation is slightly elevated in the brain injured patients compared to controls, but this was not statistically significant and certainly was not clinically significant. But when she looked at oxygen metabolism, and now here I'm just normalizing all the metabolism values to our healthy controls, you can see that there's profound increases in oxygen metabolism. So these increases in oxygen metabolism are likely due to excitotoxicity and increased neuronal activity that occurs in the acute phases after hypoxic-ischemic injury. And what we now know is that brain perfusion actually is really good. So blood flow is really good at regulating to adapt to effectively normalize your oxygen saturation, which is why NIRS becomes such a poor marker. But so clearly, if you wanted to use NIRS in these patients, it would be insufficient. But when you combine NIRS with DCS, we think it's a much more robust system. So this is our system that we use in the clinic right now. It consists of an FD-NIRS component, which again, I should mention is different than the commercial systems in that it's quantitative. I can compare patient to patient. I don't have to make a lot of the assumptions that they make. And then a DCS component, which is the portion that measures blood flow again. And most importantly, this cart is on wheels. It's portable. And then these are fiber optics that are coupled to the devices. And you can kind of see the probe head here. So the patient interface is actually just quite small. So we could easily wheel this to the patient's bedside and leave it there for however long a patient needed. And this is our fancy research device, but certainly you could conceive of miniaturizing this device for extended use. So the patient interface that I alluded to in the last slide, we customize it for our specific applications. So like I was saying, the farther apart we place our source from our detector, the deeper we can go. But there's a limit, so we have to be able to detect enough photons. So we're always weighing those two considerations. But we make flexible sensors that can be strapped onto patients' heads for longitudinal monitoring. We make handheld or rigid sensors that can be used for spot measurements. So like for instance, on this preterm infant study, we tracked babies as they aged across like 6 months. We would just come in and make a couple spot measurements around the head. And then one of the great things about the technology is that we aren't just limited to humans, right? We can essentially just shrink our source and detector separation down really small and be sensitive to preclinical models as well. So this is like in the neonatal rat brain. This is some measures we took on neonatal rats and also on mice. So we can even do imaging with diffuse optics. If you want to be sensitive to larger regions of the cortex, you can design arrays of optodes that can be sensitive to full brain effectively, which there are groups that do this. This is one such example. My lab does not currently do this because it is like hours of setup to get these optodes on the patient's head. And for the majority of the patients that I'm looking at, when you really have a severe brain injury or even mild to a degree, it's oftentimes just advantageous to have just a small sensor that you can just hold in place on the forehead, strap it on, and do longitudinal monitoring. Very easy, very simple, and especially when you've got severe brain injury, oftentimes these effects of are seen throughout the brain. So now that you kind of have a sense of the system that we use and the opportunities that FD-NIRS and DCS presents, I'll just kind of summarize them here. It's non-invasive, like I said, so we don't have to put bolts in the patient's head or even anesthetize them, frankly. So this is great for fragile patients like this little baby here. Second, we don't use any ionizing radiation. So the light exposure from our laser diodes and LEDs is really no more than you would be exposed to on a sunny day outside. So finally, it's portable. So instead of having to take these fragile patients and bring them to the MRI, we can come to you. And we also just take up a very small amount of real estate on the head, which I hate to keep showing this picture because it's really sad, but you can tell there's not much real estate to do monitoring, so it's nice to keep things small. Another feature that I didn't mention is that we have very high temporal resolution. We can go up to on the order of about 1,000 hertz. And so that means we can capture dynamic events as they happen, which certainly this is an example of some finger tapping experiment where we had a sensor on the motor cortex, and we're certainly able to capture the transient activity, hemodynamic activity that happens with functional activation. And finally, unlike other techniques like Doppler ultrasound or magnetic resonance angiography, we're sensitive to microvasculature. And this is kind of just a nice perk of the technology. Basically, light that goes into these large vessels that has lots of hemoglobin gets absorbed because there's so much hemoglobin. And so most of our photons that have reached our detector are primarily coming from interactions with capillary venules and arterioles. And it's great because the microvasculature is really where you're probing tissue and neuronal health. And then I don't mean to sound like a broken record and like what we do is so amazing, because it's not, right? There's definitely its downsides. We will never get these beautiful high spatial resolution images because our light diffuses. So our spatial resolution, even if we were doing imaging, would be on the order of 5 to 10 millimeters. We're also limited by penetration depth, so it's hard for us to measure features that are deeper than like superficial cortical structures. So I really see NIRS and DCS as a complementary tool to lots of the, to these many different other imaging and monitoring modalities that are out there. Okay, so I thought I would talk to you today about two different main applications that, so one is a clinical application where we were looking at patients with congenital heart defects. And I'll touch upon a few of the studies we did with them. So roughly 2 to 3 infants per 1,000 born each year have some form of severe congenital heart defect, with about 1/3 of those requiring surgery in the first week to month of life in order to to survive. So we specifically studied hypoplastic left heart syndrome and transposition of the great arteries. And you can see the main feature of these defects, without going into too much detail, is that there's mixing of the arterial and venous blood. And so these patients grow up in utero in basically a hypoxic environment. And now that surgical techniques for these procedures, like within the past 30 years, have dramatically improved, there's this shift in clinical focus from just strictly survival to now improving neurological outcomes and preventing neurological injury. So these patients have similar neurodevelopmental outcomes to preterm infants in that they have ADHD, speech and language abnormalities, some motor deficits, impaired visual spatial skills, a whole smattering of deficits. And just to give you a sense of the severity of these patients' images or injuries, these are kids who, I'm not going to talk about this particular study, but these are older kids who came back and we monitored them. And you can see this, they were like anywhere from 6 months to 5 years, and they had things like excessive CSF, enlarged ventricles, and then all sorts of, the increased bone marrow. I mean, basically, if I can tell that your MRI doesn't look good, it's not a good thing. So I think what's important to keep in mind here is these patients have to go to surgery to survive. So even though they have these cognitive deficits, they're better off than they were. The three main brain injuries that we see in these patients are periventricular leukomalacia, or PVL, which is just a fancy word for white matter injury. They have stroke and also some hemorrhaging. And, unfortunately, the incidence of these brain injuries more than doubles after they undergo surgery. So there's something that's happening in this pre to post-operative period that's leading to increased injury, and we want to understand this better. So we thought, can we use NIRS and DCS to study the brain in these patients and identify risk factors for these brain injuries? And ultimately how they might be prevented. So this was our study protocol. The patients were born. Within 1 to 8 days, our patients went to surgery. Before surgery, they got a preoperative MRI, and we used NIRS and DCS concurrently during the MRI scan. Then they went to surgery and returned to the cardiac ICU, and then 3 to 15 days later, they received a post-op MRI to assess any new or worsened acquired injury. This is sad. It took 4 years to acquire all this data. These patient studies takes forever, right? I guess it's a good thing that there aren't that many of them, so from a research side, it takes a long time. I forgot I included this in my slide. Anyway, so one of the first things we did was, we were taking these measurements in the MRI, and at this point in time, these technologies were brand new and really had just been tested in the laboratory, and so we validated these techniques against our gold standard MRI. So we were measuring just resting state oxygen saturation, blood flow, and metabolism, and we compared to phase contrast MR to get blood flow and susceptometry MR to get venous saturation, and both of these measurements were in the sagittal sinus. So again, we were kind of looking at macrovascular flow versus our microvascular level, but we were expecting them to be roughly correlated. And that's exactly what we saw, looking at oxygen saturation for NIRS compared to MRI, beautiful correlation. DCS versus MRI, also very nicely correlated, as well as CMRO2. And then next, we were able to do a hypercapnia challenge where we gave the patients carbon dioxide, which is a potent vasodilator. And similarly, we saw nice agreements between the relative changes in our optically measured parameters and the relative changes in our MR measured parameters. So using this preoperative data, we characterized, for the first time, just resting state hemodynamic and metabolic parameters. So we found that, so here I'm reporting our heart disease cohort as well as literature values for healthy infants, which are really sparse because nobody would do these measurements in a healthy baby, but there are very few publications out there. So But anyway, so what we saw was that oxygen saturation was significantly decreased, which is expected, right? Because these patients are hypoxic essentially due to their heart defect. Oxygen extraction was significantly increased, blood volume was decreased, flow was decreased, and so was oxygen metabolism. So given that we saw decreases in preoperative cerebral blood flow, we wanted to assess whether this was because they were supply limited, right, that their heart wasn't able to just provide enough blood to their brain, or whether they had impaired vascular reactivity. So something about this hypoxic environment had impaired those normal vascular reactive mechanisms that allow your brain to respond to physical challenges. So we gave the patients carbon dioxide while they were in the MRI. So we did like a 10-minute baseline and then increased the fraction of inspired CO2 to 3%, which again, normally you wouldn't be able to do in babies, but CO2 actually used to be used as a therapeutic tool for these kids to improve lung perfusion, so we were able to get it through the IRB. But anyway, we quantified vascular reactivity as just the change in cerebral blood flow per change in partial pressure of carbon dioxide. And what we found was, despite the fact that our preoperative blood flow were substantially different than normal, in general, this cohort had very well intact cerebrovascular autoregulation. So this is just a histogram of all our patients, and the gray region is normal vascular reactivity, which again, we don't know what it is in normal healthy babies, but in adults, it's somewhere between 2 to 4% per millimeter mercury increase. So by and large, they were really normal. There were certainly some patients who were like off the charts, and then there were some who had really impaired vascular reactivity. But when we looked at whether this was related to the brain injuries that they were experiencing, we didn't see any correlations. Okay, and then finally, one other thing that we were sensitive to and that I thought was worth sharing about like kind of the capabilities of this technology is we were able to capture the therapeutic response to many different therapeutics that these children were given. One such condition that often they present with is metabolic acidosis, where your blood is essentially abnormally acidic, and when it becomes too acidic, it can lead to decreased heart contractility, arterial blood pressure decreases, and reduced cardiac output, which obviously is not good, so they try to treat for it. What they do is they give sodium bicarbonate, which is essentially just used to neutralize the acid. And what we know is that this treatment has been linked to intraventricular hemorrhage, hypernatremia, and adverse outcome in preterm infants. So we wanted to look at what happens in these term infants, who, by the way, are very similar to our preterm infants. So we captured 19 patients who were given this drug. They were all given it as a bolus, so very rapid administration. And what we saw was that there was this profound dose-dependent increase in cerebral blood flow when the drug was given. So this is blood flow measured, relative increase in blood flow measured 1 minute after administration versus the dose of bicarbonate they were given. And so, I mean, we expected this would happen because the byproduct of this bicarbonate reaction is carbon dioxide, which, like I mentioned, is a vasodilator. But it raises some really interesting clinical questions where, should you be giving this drug in patients who are really susceptible to rapid fluctuations in cerebral blood flow, like preterm infants, and potentially explains why sodium bicarbonate does lead to all these brain injuries in preterm infants. So, okay, so at this point, let me switch gears and talk to you about another application that we've been working on. This is a more mild brain injury in concussion, which is obviously a hot topic nowadays. So concussion is a form of mild traumatic brain injury that's caused by rapid acceleration of the brain. And it disturbs brain function, but not necessarily structure. So we're not seeing, hematomas, contusions. And these cognitive effects appear and then they get better gradually with time. And just to kind of put this in context, this is a significant public health problem. I got the numbers from Children's Healthcare of Atlanta, and in 2014, which was the most recent date they had, numbers for almost 1,800 kids presented with concussion. And of those kids, 25% had repeat concussions, which was just mind-boggling to me. I feel like if my kid got a concussion, I'd be like, you're never going outside again. but yeah, like one kid had his 7 prior concussions. It's just crazy. So we know that repetitive concussions and subconcussive impacts that occur within this vulnerable time window after the first concussion can worsen neurological symptoms and increase their duration. You know, most patients recover fairly quickly and they're fine. But there are a significant number of patients, something like 10 to 14 to 40%, depending on literature reports, who have long-lasting effects. And I mean, long-lasting like a year, a month, a year, maybe even longer. And so the question is, you know, what is unique about these patients? Who are they? Why are they most vulnerable to concussion? And who are the ones who are going to be getting these long-term cognitive effects? And then why are they getting these worse outcomes? So it's been demonstrated that mechanics alone are insufficient to predict outcomes. So what else could be going on? So we started with just a mouse model of concussion. I'm very interested in doing clinical concussion studies as well because we can, but it's really challenging, right? Clinical concussion, people have multiple histories of concussion, they present at different ages, and you know, sex plays a role, and then you have really very little control over when you can measure them after the concussion. So we started with this mouse model where we can control everything fairly well. And our mouse model is a closed head injury model. The mice are anesthetized. So we have them on this plexiglass plate that has can you guys see the mouse? There's a Kim wipe taped along the plate, and there's a hole in the plate. So the mouse is really just resting on this Kim wipe. And we grasp their tail, and then we drop a bolt on their head. And you can see the slow motion video of it. Basically, when the bolt impacts them, it breaks the Kim wipe, and their head rapidly accelerates in the anterior or posterior plane. And so recently, our lab has been characterizing the biomechanical injuries, or the biomechanics of this injury. And we found that, so here's rotational acceleration as a function of time. And when we scale these values to the equivalent of what a human would see, we actually see that it's roughly a third of the thresholds that are that are reported for human concussions. So maybe this is not really a mouse model of concussion, but better a subconcussive injury, which we all know from the news lately. These also are very detrimental, so it's still a very relevant model, I think. So the consequences of this model are really subtle. There's no obvious structural damage. They don't have skull fractures or hematomas. And after a single closed head injury, there's really no cognitive deficits as seen by Morris-Waterma's tests of spatial learning and memory. So I don't know if you guys are familiar with Morris-Waterma's, but basically the mice are trying to find a hidden platform, and as you try them again and again, they get better at finding this platform. So you're looking at the latency, the time to find the platform, and it should improve. No difference between sham and injured. But as we increase the number of hits spaced once daily, cognitive deficits start to emerge. And this is 5 injuries spaced once daily, and I didn't show it here, but basically, you know, 2 injuries, they might have mild cognitive deficits. 3, there's a little more, and then with 5, there's a lot. So they get incrementally worse. And I just wanted to show this here, which is super messy, but what you can see, this is the individual time traces of all our sham injured in blue and our concussed mice in red. and their means are in black. And they're all over the place, right? There are definitely more red mice who have worse outcomes than the blues. But what is it about these red mice who didn't get cognitive deficits? And what is it about the red mice who have profound cognitive deficits? So that's what we're trying to answer. We've also done immunohistochemistry to look for neuronal injury in this model. And for this particular group of the ones who had 5 concussive injuries, so the most Morse-Water-Maze deficits, we basically saw no neuronal degeneration, no axonal injury, no DNA damage, and no brain-blood barrier permeability. And just to kind of prove to you that it's not just we are bad at immunohistochemistry, we also have data from a more severe model where we can clearly see that neuronal injury is starting to emerge. So, so we have this repetitive model that doesn't result in overt neuronal injury, and yet we're seeing cognitive deficits. So why is that happening? And this work is ongoing, but I wanted to show you some of our initial results. So we started with DCS measurements of cerebral blood flow, and we designed a custom optical sensor that would be sensitive to cortical perfusion in the mice. We measured over the right and left hemisphere. We positioned our probe over between the Bregma and lambdoid suture. We made the measurements in mice who've been nared, but otherwise they're completely non-invasive. And they were made under anesthesia, I should highlight as well. But my students have designed this awesome custom mouse restraint so we can start making measurements in awake mice, but I don't have that data here. But basically, the goal is to eliminate the effects of isoflurane, which we know is a potent vasodilator and influences cerebral blood flow. So this was our study protocol. We had our group of mice who just underwent 1 closed head injury, measured at baseline, 4 hours after, and then 24 hours later. And then we had our repetitive injury model, which was at 5 hits spaced once daily. And we measured at, a sampling of time points along this injury progression at baseline, after the 3rd injury, after the 5th injury, and then 72 and 2 weeks later. And we did Morse-Water-Maze testing at that 72-hour time point. So what we saw was that a single closed head injury resulted in transient decreases in cerebral blood flow of about 30% that resolved within 24 hours. And similarly, this repetitive model also caused decreases in cerebral blood flow. I changed up what I was plotting here. So now this is relative change in blood flow from baseline levels. So this dotted gray line would be if there's no change, just like the sham see because they're not being injured. But you can see after the 3rd hit, there's decreases in blood flow, and after the 5th hit, there's significant decreases in blood flow. And by 72 hours later, everybody's returned back to baseline, and I didn't plot it here, but the same thing is seen at 22 hours. So then looking at their cognitive deficits, these mice were longitudinally tracked. So we were able to capture Morse-Water-Maze in the mice that we were measuring these longitudinal changes in cerebral blood flow. And basically, we see significant deficits, but this is despite the fact that blood flow at this time point that the Morse-Water-Maze measurements were taken, blood flow had returned back to baseline. So the cognitive deficits were present despite back to normal blood flow. But we thought that maybe blood flow early on could be a prognostic measurement of who was going to do worse on their Morse-Water-Maze later. So what we found was that baseline cerebral blood flow before any concussions was associated with behavioral outcomes after these 5 concussions. So here I'm plotting the average Morse-Water-Maze latency across those hidden 5 trials versus their baseline cerebral blood flow. So you can see for the sham mice who weren't hit, there's no correlation. But for the injured mice, the lower the mice started off with, the lower flow that they started off with, the worse they performed after they had all their concussions. And the similar trends were seen at this 4 hours after the 3rd time point. So the extent of the decreased cerebral blood flow observed at this time point was correlated with worse cognitive outcomes. So if this finding translates to humans, one, it could be really useful in identifying athletes or soldiers or children who are at risk of subsequent concussions once they get one. And then I think this work is also exciting because it provides us with a platform where we can first measure cerebral blood flow prior to any injury or maybe after the third injury. We can euthanize the animals, harvest their brain, examine pathological mechanisms that are going on, and then relate these pathological changes to the predicted Morris-Water maze outcomes that we're thinking the mice are going to have based on their cerebral blood flow measurements. So along these lines, we've started looking at mechanisms of injury. We isolated two main potential mechanisms of what's causing this decreased cerebral blood flow: neuroinflammation and potentially nitric oxide synthase. So neuroinflammation has certainly been implicated in severe TBI, and then, but less has been investigated in mild TBI. And similarly, nitric oxide synthase is a regulator. Am I almost done? Okay, I'm almost done. I have like just a couple more slides. So nitric oxide synthase has also, it's a regulator of vascular tone and has also been implicated in damage. So we started with a pilot cohort of just n equals 8 animals. We measured cerebral blood flow at this 4 hours after the third injury. We harvested their brains. We stained for IBA1 to look for activated microglia. And these are two representative animals. You can see, maybe you can see that some, were fine, but then there are others who had significant numbers of increased IBA1 positive stained cells. And what was interesting is that those mice who had higher presence of IBA1 positive microglia had lower cerebral blood flow. And remember, the guys who have lower cerebral blood flow are the ones who have worse cognitive outcomes. So this is suggesting a role of neuroinflammation potentially in long-term. Similarly, at the same time point, we looked at endothelial nitric oxide synthase, which is, like I mentioned, plays a role in vascular tone. And we saw that the lower the cerebral blood flow, the lower the eNOS expression. And so I think this is all the data I've included from the study so far, but we just submitted a grant to explore these mechanisms further and to test the hypothesis whether cerebral blood flow and neuroinflammation are mechanistically linked after repetitive concussion. So in conclusion, hopefully I've shown you the kind of breadth of possibilities that we can do with these diffuse optical techniques to measure oxygenation, blood flow, blood volume, metabolism, and then the potential they have to possibly influence patient care through therapeutic monitoring, developing prognostic biomarkers, and investigating mechanisms of injury. And right now we're applying this technique not only to concussion, but cardiac arrest and sickle cell disease and hypoxic-ischemic encephalopathy. And we're always looking for new applications and new collaborators, so feel free to contact me if you're interested. With that, thank you for your time. I appreciate it.